Good evening. I'd like to call to order the meeting of the Finance and Property Committee at 5 o'clock. I'd like to ask Dr. Zimbalati to read the land acknowledgement, please.
Thanks, Karen. The Health Unit is situated on lands that are the traditional territory of the Anishinaabe people who continue to live, work, and play throughout these territories, including in urban communities. I encourage everyone to think about how they may contribute both personally and professionally to the process of reconciliation and respond to the 94 calls to action of the Truth and Reconciliation Commission of Canada.
Thank you, Dr. Zimbalati. 3.0, approval of the agenda. Be it resolved that the Finance and Property Committee agenda dated February 25th, 2026 be approved. Can I have a mover? Rick, thank you. Seconded by Jim, thank you. Oh yeah, sorry. That's why I actually had to sit beside me to hold my hand. So for Rick Champagne?
Yes.
Karen Cook, yes. Blair Flowers?
Yes.
Jamie's not here. Jamie McGarvey?
Yes.
Jamie Restuel?
Yes.
Tim Shepard?
Yes.
Marianne Strickland?
Yes.
And Dave Wolf.
Yes.
4.0, does anybody have a conflict of interest to declare at this point? If not, if anything changes, please let us know. 5.9, presentation, the audit planning report. We would like to welcome Derek and Sarah. Hi, guys.
Hello.
Oh, I think the floor is yours.
Oh, great. So thank you for inviting us to present our audit planning report for 2025. Both Sarah and myself will be sharing the duties and going through the report with you. If you have any questions, please just don't stop. You can just stop us along the way and we'll try to answer them right there, or you can wait to the end, whatever's more convenient for yourself. So again, just as a little bit of way of introduction, again, my name is Derek D'Angelo. I've been your lead audit partner for the last 4 years, and Sarah has been your lead engagement senior manager for the 4 years as well. So looking at the planning report, which I believe you have, I'm not going to talk too much about the audit highlights screen because we cover most of everything in this report on individual slides. But we will talk about specifically about the materiality that's being set, and I'll let Sarah take it from here.
No problem. Thanks, Derek. So our materiality is determined at a level which we consider that misstatements could reasonably be expected to influence the economic decisions of users. So our initial materiality is determined to provide a basis for risk assessment in determining the nature and extent of our audit procedures. And it's also used throughout the audit to identify misstatements and uncorrected misstatements on the financial statements. We reassess materiality throughout the audit. So once we set the initial materiality, we reassess it as we work throughout the audit and revise it if we become aware of any information that would have caused us to determine a different materiality level initially. Should there be a change in materiality throughout the audit, we will communicate the revised amount to you through the audit findings report when we present at the end of the audit. There are various benchmarks, that can be used to calculate materiality, including total expenses, total revenues, and total assets. Initial materiality is calculated based on prior year total expenses, adjusted to remove the impact of mass immunization funding, as it is not expected to occur and has been decreasing over the past few years. Accordingly, materiality has initially been set at $667,000, which is based on 2.8% of total expenses, which is fairly consistent with what you would have seen last year. And it's in the acceptable range for materiality, which is between 0.5% and 3% of total revenues. Not really going to touch on standards because we do have a little slide on it as part of the appendices, and we'll talk about it at that point in time. With respect to significant risks, based on historical audit results and our risk assessment procedures that we have completed, the only significant risk that's been identified is related to management override of controls. This is a non-rebuttal significant risk of material misstatement that applies to all clients due to management's unique position to manipulate accounting records and prepare fraudulent financial statements by overriding controls. It is not a new risk, so it would have been communicated each year since we've been completing the audit. In response to the risk, we will be conducting some specific procedures, including test and journal entries, performing a retrospective review of any estimates, and evaluating the business rationale of significant unusual transactions. We also have some required inquiries of the audit committee that we address each year around fraud, financial reporting, compliance with covenants, related parties, and significant unusual transactions. And we'll set up a call during field work with a committee member to go through the inquiries, but the subject of the inquiries is on the screen. And just with respect to milestones and deliverables, we have been performing our initial risk assessment and planning procedures during the months of January and February. And we plan to complete year-end fieldwork in March. I believe we're around March 23rd and March 30th, we'll be completing fieldwork with final reporting due in April. And Derek, back over to you for quality.
Sure. So one of the things at KPMG is we define audit quality as being when audits are executed consistently in line with the requirements and intent of the applicable professional standards within a strong system of quality management, and that all our activities are undertaken in an environment of objectivity, independence, ethics, and integrity. We as KPMG have implemented a very consistent risk-based approach to our system of quality management, which enables us to meet the requirements for the International Standard of Quality Management, or known as ISQM1. And we look at that in the next slide. We talk about how we deliver audit quality. And again, we have to make sure that all our audits follow ISQM1, which is issued by the International Audit and Assurance Standards Board. And in alignment with ISQM1, we've created our own system of quality management, which meets the requirements, again, of the International Code of Ethics for Professional Accountants and the International Ethics Standards Board. So basically, we take the international standards and we've enhanced it for the Canadian practice to make sure that our system is as strong as possible. And again, performing quality engagement is our core tenet in when we complete an audit. And again, part of that is continually monitoring and remediating to make sure that all our audit quality drivers are being complete, which you see in the graph on the right-hand side. And again, these are just things that we do throughout the audit to make sure. Some of the ones would be making sure that we're selecting and working with the right clients and engagements, making sure that we're independent, objective, and ethical. We're always assessing risks to the quality. We're applying the appropriate level of expertise and knowledge to the audit engagements, and make sure we have diverse skilled teams on the audits. So the bottom right of the chart is really what the important thing is we want to do the right thing always, even if it means doing more audit work. You'll see you may have comments from your staff at points like, why are they asking for all this information? It's part of the standards that we have to get detailed information, but we're always making sure that we're following all the applicable standards. One of the things that we also do throughout the course of the audit is, and we'll report on this as part of our audit findings report, is we look at the indicators of audit quality. So some of the things that we look at is when we select your engagement team, we make sure that you have a team that has the appropriate experience with the engagement, with the industry, to make sure you're getting people who are knowledgeable of, first of all, your entity and as well the environment that they're working in. Again, you have both myself and Sarah, who have been with you now for, this will be our 5th year. I also do audits for 2 other public health units, and have been doing them for probably about 10 plus years now. So we'll report on all of those details at the end of the audit. One of the other things that we look at is when we ask for information, this is what we call our PBC listing, prepared by client listing. We're making sure that when we ask for something, we're getting it in an appropriate manner, a timely manner, to make sure that we're meeting all the deadlines for the audit that everyone has set. We also look at the implementation of technology in the audit. You know, how much technology will we use? And again, these are things that audits are continually evolving, especially right now, that more technology is being used year over year. So again, I have a slide later in the slide deck that'll kind of give you a little benchmark on where we are with things. Quality reviews for our files can be selected both for internal and external review. If your file ends up having to be selected for either internal or external review, we will report on those findings to you. Currently, it has not been selected in the last 4 years, so it's not one of the files we need to report on. But if it does get selected this year, we will let you know the results of that review. And finally, one of the engagement focuses, we will report on the number of hours or the percentage of hours spent by each level in completing the audit. What this really is important is you want to make sure that you're getting an appropriate level of senior resource time on your file. So really, when you look at this metric, you're kind of looking at, you know, how much time do Sarah and I spend on your engagement. And there are particular metrics that are considered reasonable for audit partner and audit manager hours on engagements. And we'll report all this to you in our audit findings report. One of the other important things is to make sure that we're independent, and we apply all ethical requirements in making sure we're independent, and we follow, again, all the rules of professional code of conduct in ensuring that we're independent of the public health unit when we do the audit. So again, as mentioned, we have a strong system of independence quality controls. We will get pre-approval of any services that are required in completing the audit, and we'll report on independence at the end of the audit in our audit findings report. So as mentioned, again, we are going to complete the audit for the health unit for December 31st, 2025. And again, that's just the same engagement that we've been engaged for the last 4 years.
Okay, just moving on to a few of the appendices. We won't go into detail with all of them, but to just give you the highlights. So we have attached to the most recent engagement letter, which was dated February 4th, 2026. The full letter is included in the package to make sure that we're compliant with audit and standards regarding effective two-way communication with the board. It is a standard engagement letter with no modifications to the letter or the terms. Moving on to newly effective and upcoming changes to accounting standards. So there's nothing new in the current year or next year at this point in time, but there is a new public accounting guideline coming into play effective for year ends beginning on or after April 1st, 2026, which would mean 2027 fiscal year for the health unit. There's no change in recognition or measurement, but it will result in changes to the financial statement presentation, primarily to the statement of financial position, but we don't actually expect the new standard to have a significant impact on the health unit's reporting. There are a couple of new auditing standards have come into play this year. No impact on the audit. It's mostly around communication and independence, which Derek would have primarily covered in previous slides.
One of the other things that we will provide and would have available to any member of the committee is if there are any changes in sustainability reporting, any changes in accounting guidelines, audit guidelines, any of the new hot current topics. If there's something that anybody in the committee is looking for, we do have a lot of resources available on our kpmg.ca webpage. You can find a lot of documents there. So really, this just kind of gives a sense that we do post and have a lot of resources available to members of audit committees and finance committees. Maybe I'm just going to go right to the next slide, Sarah, if you don't mind.
Yep. No
So as mentioned, talking about technology in the audit, and I said I would have a slide on this. And I always like to look at this from the right to the left, because really I believe we're moving more right to left than left to right on this slide. So when we look at our audit technology, we really did start many years ago on the workflow side using what we call KPMG Clara, which does both account analysis, journal entry analysis, as well as planning analytics. Then we also move now into collaboration where we're using DocuSign so that documents are be able to sign electronically, and the KPMG Clara sites where it's a two-way sharing of documents that can be used. So when we ask for documents, your staff can upload them to a secure database. When we start getting into automation, we are starting to use things like Data Share and Data Snipper to basically be able to extract data from reports a little easier. And again, a lot of this is more on our end of being able to make us a little bit more efficient in how we audit. And then I think the final stage is now on the analytics stage, which I believe we're not going to be doing very much of in 2025. But we'll be, again, looking into the future. These are more items that are available on very large audits that would have millions of transactions to analyze. It's not required yet for North Bay Public Health. But again, that is where the future is heading in the audit world for various sizes of entities. But we will not be using AI on the audit. It's just some people have questions about that, and we're not at that phase yet for North Bay Public Health. And again, as this whole process happens, again, we're just looking to, it's a continuous evolution. Basically, all this standardization and automation in the audit routines are trying to work within our quality management system to both enhance audit quality, increase the efficiency, and make sure that both staff and our clients have exceptional experiences throughout the course of an audit. I'm not going to go into this slide much on the next generation technology because, as I mentioned, we're not using it. And again, generative AI, we do use KPMG Clara, but we're not using the generative AI portion of it at this point. Again, that's related to large audits at this point. So really, that's our presentation for the audit planning report for 2025. And we'd both be more than happy to answer any questions from the committee.
Anybody? No? No questions. So thank you very much, Derek and Sarah. Thanks for joining us today.
Thank you.
Thank you very much for allowing us to join. And again, we appreciate also being able to present remotely today. It's been convenient with our schedule. So thank you very much.
Yeah.
Take care. Bye.
Bye.
Great. 6.0 approval of the previous minutes. Be it resolved that the minutes from the Finance and Property Committee meeting held on January 28th, 2026 be approved as presented. Could I have a mover? Dave.
Jamie, that's the rest also.
And Jamie, thank you. Okay, Rick Champagne.
Yes.
Aaron Cook, yes. Blair Flowers.
Yes.
Nobody's not here. Jamie McGarvey.
Yes.
Jamie Ristool.
Yes.
Tim Shepard.
Yes.
Marianne Strickland.
Yes.
And Dave Wolf.
Yep.
Great. 7.0 date of the next meeting. The date of the next meeting is April 22nd, 2026. Time to be determined here in the Nipissing room. 8.0 business arising. I don't believe we have any. 9.0 is new business. 9.1 is fourth quarter financial statements, which we have in our package. So does anybody have any questions? Okay. 9.2, fourth quarter medical officer of health expenses, again in your package. Any questions? 9.3, fourth quarter board of health expenses. Any questions? 9.0 is in Cameron, and we don't have anything there. And 10.0 is adjournment at 5:21.
Great job, Madam Chair. We'll call a meeting to order. We have the approval of the agenda. Need a mover and a seconder, please? I'll approve. Karen? To be resolved, the Board of Health agenda dated February 25th, 2026 be approved. Rick Champagne, yes. Karen Cook.
Yes.
Blair Flower.
Yes.
Jimmy McGarvey.
Yes.
Jimmy Restool.
Yes.
Tim Shepard.
Yes.
Mary Ann Stickland.
Yes.
Dave Wolf. Thank you. Carried. Three point oh, conflict of interest. If anything comes up during the meeting, please let us know. 4.0, approval of the previous minutes. Need a mover and a seconder, please. By Karen. Oh, and Jamie McGarvey. It resolved that the minutes from the Board of Health meeting held on January 28th, 2026 be approved as presented. Karen Cook.
Yes.
Champagne, yes. Blair Flower.
Yes.
Jimmy McGarvey.
Yes.
Jamie Restool.
Yes.
Alex Scott, sorry, he's not in. Tim Shepard.
Yes.
Mary Ann Stickland.
Yes.
And Dave Wolf. Any discussion on the minutes? No? See none? 5.0, date of the next meeting will be April 22nd, 2026 in the Nipissing Room on the main office in North Bay. 6.0, business arising. I don't think there is. Report of the medical officer of health. Did we have any written questions or anything ahead of time? No? Okay. Dr. Zimbalati.
Yeah, so the report is in your package. And I've been increasing communication to municipalities. I've been sending a package starting last Board of Health meeting that it contains my update as well as highlights from the MOH report, just to allow busy council members more opportunity to understand what's happening. So this update will be included in that.
That's great because people have asked about it, and it's not just good reading material. At least it keeps everybody in tune what's happening at the health unit and the importance of the health unit. So thank you for that.
The full report is obviously included as well. This gives them entertain questions.
Any questions for Dr. Zimbalati? I see none. Thank you so much. 8.0, board committee reports.
We don't have any.
Don't have any?
No.
Okay. Correspondence? We've all looked at it. Any questions? Okay. New business. 10.0, 10.1, Association of the Public Health Agency Alpha Winter Symposium Summary. Before you speak on it, Dr. Zambelatti, I know there's importance of us attending to some of these. I know I did say before, just to make sure if you are attending, to make sure you do attend, but it'd be nice to have some board members that will attend. So I know you have a report on it, but it's nice to either we take turns or over the cases. I know myself and Mr. Shepherd are going to the Alpha conference in June, but if some other ones come along, it'd be nice to at least get some of our board members there, if at all possible.
So I did provide some highlights from the meeting. It's always interesting to hear the Chief Medical Officer of Health speak and understand what he's highlighting in his talk, because that really does give us some insight into ministry workings. As well, there's lately been sessions from legal advisors of Alpha, which they're really, I would say, geared to Board of Health members. So it is, they're valuable sessions to attend. But hopefully that my notes provided some insights from that talk.
Just a minute.
Any questions for Dr. Zambelatti? Standing here. Thank you, Dr. Zambelatti. We'll move on to 10.2, strengthening coordination of the provincial and federal dental program. I believe it's Shannon that's speaking on it.
Yes.
Thank you.
Thanks. I'll give a high-level summary. There's a briefing note in your package. So with the introduction of the federal dental program, which we call CDCP, it's created unintended access barriers for vulnerable populations. And this is due to misaligned coordination with the existing provincial programs that we have here in Ontario. So Ontario requires that the federal program be the primary payer when clients seek care, and when they qualify for both the federal and the provincial program. And there's gaps in implementation that cause delays and reduced access to dental care. Local service providers and social services, as well as public health units in Ontario, are reporting, including us, are reporting that some providers refuse to treat clients using the provincial programs, such as our Healthy Smiles program, which is for children. Ontario Works in ODSP, so they're refusing these clients until they're fully enrolled with the federal program. The problem with this is that it affects individuals who are most marginalized. So individuals who are waiting for CDCP approval, they may have applied, but it takes some time. They can't apply due to lack of a tax return or ability to get one. Maybe they don't have a home address. They've just learned about the program, or they're newcomers and asylum seekers. Children enrolled in our Healthy Smiles Ontario program are also experiencing reduced access, as many providers, or almost all providers, won't see them until they have the federal program and they're fully enrolled so they can coordinate benefits. So as a result, as I mentioned at the beginning, the most marginalized populations, or those with the highest needs, are experiencing greater delays in care than before the federal program came into effect. This creates inequities and increases risk for dental health issues and emergencies. So the resolution before you in the briefing note really speaks, it calls for improved federal and provincial coordination. It calls for clear, consistent guidance for dental providers on how to navigate the dual coverage and how that works. Streamlined processes, and just as an example, maybe temporary coverage for people awaiting their application to be approved, as well as a dental workforce analysis, just to get a sense of the landscape of dental professionals and the geographic distribution across Ontario, specific to us, maybe in the north as well. So a similar motion's been endorsed by Windsor, Essex County Board of Health, and some other boards of health now. So yeah, it's for your consideration. I don't know if you would add anything, Dr. Scully?
Any questions for Shannon? Okay, I see none. I'll read the resolution and go from there. So moved by Jamie Restool, second by Mary Ann Stickland. Whereas oral health is a vital component of the overall health and access to the dental care remains a significant barrier for many low-income, marginalizing, and vulnerable population. And whereas the Government of Canada has introduced the Canadian Dental Care Plan to improve access and dental care for eligible uninsured Canadians. And that whereas the province of Ontario administers dental and social assistance program, including Healthy Smiles Ontario, Ontario Health Dental Plan Care, Ontario Works, and the Ontario Disability Support Program, which provide dental benefits for priority population, and whereas the Public Health Unit plays a critical role in supporting access to oral health services for vulnerable population, and whereas the current coordination requires designation and Canadian Dental Care Plan as a primary payer have resulted in unintended barriers to timely dental care for individuals who are eligible for provincial programs but are not yet enrolled in a Canadian dental plan due to administration and systematic barriers. And whereas the Windsor XSX County Health Unit has brought forward a resolution calling for improved coordination between the federal and provincial dental programs to ensure equitable and timely access to care. Now, therefore, it resolved that the Board of Health of North Bay Parry Sound Health Unit endorse and support the resolution presented by the Windsor Essex County Health Unit regarding strengthening and coordination between the Canadian Dental Care Plan and the Ontario Dental and Social Assistance Program, and be furthermore that the Board of Health of North Bay Parry Sound Health Unit urged the Government of Canada and the Provincial of Ontario to strengthen coordination, clarify guidance, and streamline administrative process to reduce delays and confusion for the client and provider. And I didn't realize it kept going. Furthermore, the Board of Health of North Bay Parry Sound Unit requests the Public Health of Ontario to Public Health facilitate the contribute to the completion of the dental workforce analysis to inform policies, decisions, and guide resources, allocations, and publicly funded dental benefits. And furthermore, to resolve that the resolution be forwarded to the Ontario Ministry of Health, the Ministry of Children, Public Health Ontario, Community and Social Services, the Federal Minister of Health, of Association of the Public Health Unit, ALPHA, and the Ontario Boards of Health for information and consideration. Any discussion on this motion?
I was going to ask you to repeat it.
Oh, it's not French, I'm okay. Okay, let's vote. Rick Champagne, yes. Karen Cook.
Yes.
Blair Flower.
Yes.
Jamie McGarvey.
Yes.
Jimmy Restool.
Yes.
Tim Shepard.
Yes.
Mary Ann Stickland.
Yes.
Dave Wolf.
Yes.
Carried. Thank you, Shannon.
Louise and Berkshire online.
Okay, 10.3, we have a presentation from Environmental Health Summer Beach Program. We have Brent Allen. And who else is on? Luis. Oh, hi, Luis. Gagne. Floor is yours.
All right, I'm going to see if I can get this presentation into Teams here. Hope I don't screw it up. All right, can everybody see that? Just okay, I see a few heads nodding there, so I'll get going here. I have about 9 slides to get through, so I'm not going to keep everybody too long, but yeah, good evening. For those that don't know me, my name is Brent, and I'm the acting program manager for environmental health. I've been in the acting program manager for about a year now, but I've been employed at the health unit for about 23 years now, and this is actually my first Board of Health meeting. So, so yeah, thanks. Tonight, I'll be presenting an update on our summer beach program and sharing the results of our program assessment, including the rationale for shifting from sampling our beaches for bacteria to a complaint-based model with permanent signage at our beaches. We wanted to bring this forward to the Board of Health, just in case you're approached by in the community or curious with the changes that we've done. So let me see here. Okay. As everyone is aware, our district covers a large, predominantly rural geography with many dispersed beaches and water bodies. Most of our municipalities have at least one public beach, but in total, we've identified about 60 public beaches in our district that meet the provincial definition. Historically, we've only monitored about 28 to 31 of those beaches every year, so roughly half of the identified beaches. We've used a monthly sampling schedule for E. coli and selected beaches based on our own internal criteria, such as staff capacity, historical results on the beaches, and perceived beach use. Each beach currently has a 48-hour rainfall warning notice and a swimmer's itch. As I go through the slides, it's important to know and to think of some of this in the context that the overall illness risk from recreational water swimming is pretty low, and it's especially low if certain precautions are taken. Next slide here. The dots on this image show our historical 30-ish beaches that we have sampled. Don't worry about all the colors on the screen depicting our jurisdiction. That's Environmental Health's own internal, the way we split up our region. But the dots are important, and those are where our 30-odd beaches that we are currently sampling are. And this picture, it really helps highlight how dispersed our waterfronts are. It's a huge area. And it helps to highlight some of the logistical challenges and reinforces why our current sampling model is really difficult to achieve equitable district-wide coverage. All right, on to the program limitations. So these limitations are specifically pointing to our sampling program, so going out and sampling our beaches for bacteria. So there are several limitations with the current sampling model. So first, samples are not timely and only represent a single point in time. Results we often receive the results of those samples approximately 3 days after the water sample, at which point conditions at the beach have already changed or could have changed. Our typical practice, if we ever had to go back and revisit a beach for higher bacteria levels, involves a confirmatory resampling of the beach. This confirmatory resampling also increases the likelihood of the public receiving outdated risk information. We also know that water quality can change rapidly with rainfall and wind. making these samples that we are taking, making these point-in-time samples even less reliable as a public protection tool. Monthly or weekly samples will not catch these changes. A lot can happen between samples. So these samples only represent a single point of time right when we are sampling the water. Recreational water use also occurs in areas other than public beaches. So our routine sampling has always only captured a smaller portion of the actual exposure risk that we see in Northern Ontario. We have a large cottage district, and a lot of those cottage owners are using the water outside of where we are actually sampling. Furthermore, another limitation, our current beach signage that is posted at the beaches is to advise the public of higher bacteria levels 48 hours after heavy rainfall. But it really does nothing to further address other potential risks or protections the public can take, such as not swallowing the water when swimming, avoiding swimming when there are a large number of birds present, avoiding swimming when there's high wind. Our signs, I think, can do a much better job of actually communicating the risk to the public. All right, some more limitations. So from an equity lens, our current system creates uneven coverage. Some beaches in our district receive routine sampling, while others may not. This leads to concerns surrounding our responsibility of informing the public of potential risks at our beaches. There's also operational realities that we need to acknowledge. There's significant costs with couriers. There's staff time allocated to this program. There's mileage driving to the beaches to collect these samples. And we really need to think about the need to balance the need of the program, or the need, the operational realities and the benefits of the program. Our geography and courier constraints make timely lab submission difficult. This summer, we had quite a few instances with samples getting lost with our courier. And it was only due to our diligent program assistants in the program who saved us by catching the lost samples, by tracking them in the morning. And in these, I think there was probably about 4 or 5 instances this summer, redirecting those samples to another appropriate lab. Typically, we send our samples to the Sudbury Public Lab. There were quite a few instances where our samples had ended up down in Toronto, and we had to redirect those samples at the last minute to one of the Toronto labs. Finally, summer is our peak operation season and peak vacation period, so that adds another complexity with delivering this program. So given these limitations, this last year we had a really hard look at our beach program. We considered the illness risk, which I highlighted earlier on, is pretty low with recreational water, and especially if certain precautions are taken. We looked at program limitations. Those last 2 slides helped highlight some of the difficulties and the limitations with the program. The geographic realities, we have lots of beaches, they're spaced out. Obviously, there's financial implications of sampling. We have couriers, we have mileage, we have staff time. And also when we were evaluating the program, we looked at the program standards, and any change that we were going to consider had to bring us into alignment with any existing program standards that the province has given us. So that moves us on to the recreational water protocol. And under the protocol, it gives health units the ability to adopt a posting-based system when weekly sampling is unduly challenging. And given our geography, courier troubles, and the number of beaches, we felt confident that we would fall into that category. And also keep in mind that we are only currently sampling half of the public beaches, and we would like to include all of our beaches. So our assessment moved us towards a discontinuing of routine sampling and transitioning to a complaint-based investigations and permanent signage at our beaches. All right, so why individual beach postings? I was actually hoping to have a beach posting sign to present to all of you today, but unfortunately it's not ready right now. The goal of the sign is to have typical health unit branding on it, emphasizing a notice to users that the beach is not currently being tested. It will include preventative measures individuals can take to reduce the risk of getting sick when swimming, such as swimming within 48 hours of rainfall or high winds, swimming when there's algae, swimming when there's lots of birds in the water, checking the beach for physical hazards, not consuming the water, and toweling off after swimming to prevent swimmer's itch. So those are some of the key concepts that we would like to capture on the sign. You know, we have beautiful natural beaches, and we're really aiming towards a very simple, not too alarming public health messaging on the sign. So I just want to get into the signs, and there are real strong reasons to move to a permanent posting type system. So first off, the recreational water protocol supports permanent postings when weekly sampling is not feasible. And given all the limitations that I have already covered, we felt that moving to a weekly sampling schedule for 60 some beaches would just be would not be feasible. Some of the other important parts of permanent posting, timeliness. So posting signs gives immediate information to beach users rather than relying on results that are often outdated. The messaging will also be consistent across our district and across all beaches, something the current program can't achieve. I want to go back and I want to reiterate that the sampling program that we have been doing, the results that we receive only represent the water at that one particular point in time. And I think that's a real important concept to keep in the back of our minds when we're talking about why our beach postings are a good option. There's also operational stability issues. You know, the model with our complaint-based model and public postings. This model reduces our reliance on couriers and will help manage some competing summer priorities. There is a recognition that developing and putting out these signs. There will be a one-time cost for the purchase and replacement of these signs, but it'll remove some of the ongoing burden of the annual costs that we have been incurring for the last quite a few years. And it'll still allow us targeted investigations when complaints arise. So some of the annual costs, you know, there are staff time, mileage, courier costs, supplies for sampling. Not only that, but there's also costs, ongoing costs with sending a large amount of samples to the Sudbury Public Health Lab as well. All right. So next steps. What we would like to do for our next steps is do some targeted communication with our municipalities. We also have to finalize the sign design and provide some of these signs to municipalities for posting. We will also continue on responding to public complaints. And we have also engaged our communications team within the health unit to do some health promotion around beach safety so that we can get some targeted messaging out about these signs as well. I'm not really certain exactly what sort of health promotion campaign we're looking at, but it's something that we are in the works of planning for this summer. We're also we'll also have to go to our website and update our website to reflect any changes in our practice. So that's that concludes the presentation in a nutshell. I'm happy to take any questions, and yeah.
Jamie McGarvey's got a question.
Thank
Go
you,
ahead,
Mr.
Jamie.
Chair. Yeah, thank you. So I totally get the fact that you know, this is a snapshot in time that you end up doing, and you know, it's only represented by the actual spot where you took the water sample, right?
That's right.
So what is the difference in checking, like the process, okay, for if somebody, let's say, takes a sample from their well to check for bacteria and various things like that, or whether they actually take it from the lake and send it in to have it tested. So can you clarify what the difference between what you're doing with the beaches and what the difference is with that first?
Yes. So the one thing we know about lake water is that lake water has bacteria in it. It's ubiquitous. It's everywhere. Now with drinking water, if somebody is drawing water off of the lake, they really should have some sort of treatment system on their system to kill any bacteria coming in through their water system. So that's really the difference. It's the difference between a raw water sample that we had been taking from beaches versus a treated sample that individuals would be taking for drinking water.
But I know you do get samples, let's say from wells that people have, that will be a raw sample.
Yes.
So is there a difference in how that's tested? Because what I'm getting at is let's say a municipality wants to do that snapshot in time, okay, sort of thing, and they go and pick up a bottle at the health unit and go out 20 feet into the water and that sort of thing, and take a water sample, and then send it in through that system. Is there anything stopping them from doing that, or is it going to be any different?
No, the public technically could take a raw water sample from an intake from their potable water line. That is possible. The public health lab would frown on it, and they actually wouldn't run the sample if they discovered that was happening. Now, the difference between a sample from a well versus a raw water sample in the lake, both are single points in time. However, the lake water draw is an unprotected source versus a drilled well we consider a protected source. So with a drilled well, we have the filtering of the soil, we have the time that the water takes to infiltrate into the soil, and by the time the water gets down into the well, it's had enough filtration. So we consider the two a little bit separate. One is a protected source, one is an unprotected source. An unprotected source, we could have, animals swimming in the lake, birds flying overhead and doing their business in the water and contaminating it. That's unlikely to find. If the same thing happened to a well, it's unlikely that any fecal bacteria would find their way into a person's well because it is considered a protected source. Hope I answered your question.
Well, I guess I totally understand what you're saying, and but what I'm getting at is if a municipality wanted to put one person's name on it and send a water sample in, you're saying that you're kind of frowning on it, but would it be okay to be done?
Dr. Zimbalati will answer the question for you.
Okay.
I believe there are instances, and it is supported in the protocols or not in the standards, where municipalities can take over the beach sampling if they choose to, using appropriate protocols and appropriate processes. I believe, Brent, you might have further information on this, but I believe, for instance, Toronto does this because they sample some of their beaches on a daily basis. Now, with Toronto, there's less of a division between the city itself and the health unit there, because it's not an autonomous board. But I think there could be some potential for that. I would stress, though, that this sampling honestly is fairly meaningless in terms of the results you get back. You think about how a sample is taken, and it's to go into the water to a depth of about a meter and a half. Try not to disturb any of the sand at the bottom, and wait. If you see the turbidity, wait until it settles, and then take a sample between 15 centimeters and 30 centimeters below the surface, because the surface is more likely to be contaminated. So if you think about your typical user of a beach who's most at risk, your toddlers, most at risk of illness, they're not doing that. They're not going a meter and a half deep. They're disturbing the sand like crazy. They're eating the sand potentially. So it really, there's some pilot studies that suggest that within kind of a typical range of bacterial counts, it's not the bacterial count that's the most likely indicator of whether a person's going to get ill. It's their behaviors on the beach. Right. So it's whether they're eating sand, so whether they're digging themselves into the sand to get that skin infection. It's are they swallowing water? So
Amy?
Yeah, I totally understand the whole process and everything. I guess because number one, the general public will say, you know, goodness gracious, the public health's not doing that anymore or whatever, and that kind of stuff, and we're not protected. So my suggestion would be that you make sure that you have enough documentation go with the what when you're putting this out to the municipalities, so that the public will generally understand as well that this is only a snapshot in time, and that if a municipality wants to do it on their own, they can to monitor it more closely. It's just that some municipalities might understand that once a month really isn't doing a whole lot anyway, but there just needs to be that communication, I think, which is going to be really important, so that they do understand that what is being done is a very small portion of the overall bigger picture of the water and where you actually sample and that sort of thing. I just want to make sure the communication piece is good enough that they understand it.
Do you have an answer to this, Louise? Because we have another question from Dave Wolf.
Go ahead and answer the
Go
question.
ahead, Louise.
Okay, thank you. Point really well taken, Jamie. And we do intend to do a couple of virtual sessions with our municipalities. So following up on this meeting, we have a letter prepared to go out to them and to all of the municipalities with the briefing note attached, and inviting them to attend a couple of virtual presentations and Q&A sessions. And we're really hoping that the questions that we get from our municipalities will help inform the messaging that also goes out to the public, and that they can also help us with that communication moving forward. We do have an example from Public Health in Sudbury District who moved to this direction last year. So they didn't conduct any beach sampling in 2025 and moved to posting all of their beaches. So we do have some examples from our public health neighbors of where this has been done. And as you said, the communication is really critical.
Thank you, Louise. Mr. Wolf?
Mostly for Dr. Zipolati, if I can. Is water sampling, and forgive my ignorance on the matter, part of our core mandate?
So as Brent indicated, there is provision within the standard to go to a system of posting every beach when it is considered unduly I can't remember the wording, Brent, but
unduly challenging.
Unduly challenging to implement the protocol of beach sampling.
Okay, the only reason I ask is because if there is the perception of a public expectation that we are doing this, and I agree with the answer to Jamie's last question regarding communication. If the expectation is there that we are to do this, that has to be very clearly explained, and not in technical terms, not in medical terms, in layman's terms, very, very basic language, nothing that is going to be well above the average grade 10 level, so that it's really clear why we're moving to this process, which I have no issue with the process, by the way. I'm not questioning that. I just want to make sure that was clear in regards to communications. Does the change, what's the net positive change to our bottom line? Like, how much, when Brent talks about the costs associated with doing this, when we stop doing this, that's going to return some form of savings. And I know that there will be costs for the signage, but I have some background in that area, so I'll speak to that in a minute.
I can't speak, like I would say the biggest bucket of expense
is the courier cost, and I couldn't give you a dollar figure on that. But more importantly, I think it is the staff time. And so by not doing the beach sampling, we're hoping that we will be able to address more fulsomely some other inspection priorities, which present higher risk to the public than recreational water use. So things like community events, where right now, summertime is the peak season for community events. And right now we've only really had the capacity to address events of where we expect the attendance to be over 500 and haven't been able to get to those smaller community events. But, with a bit more staff time to be able to dedicate, we might be able to address more of that. Also, some things like small drinking water system inspections, which those are very time consuming and hard to keep on top of. So, we would be able to dedicate a bit more time to that sort of inspection as well. So I think we're looking at opportunity costs as well as just the bottom line costs.
So we're going to reallocate those funds towards, okay, that's fine. Can we see that at some point, what the reallocation look like? Just at a high level, all if that's possible, just to give us a sense of whenever we change what we're doing, the public doesn't like change. So whenever we change something that we're doing and there's an expectation that we're going to continue to do that, if we're reallocating those funds and it gives us the opportunity to justify the change, in my view, that's a win for this table to be able to point to that. The signs, if I read correctly, the signs will be provided to the municipalities to post. What if a municipality says, I'm not posting that sign, it's not my sign? You put it up. Who owns the signs? Who's responsible for the ongoing maintenance of the signs? Who will make sure that people aren't vandalizing the signs? So are we going to have people that are going to go and check on them? Logistically, it brings up a number of questions.
So currently there are signs at most public beaches. We're already doing that kind of work. We provide the signs to the municipality, and it is the municipality's responsibility to erect them, display them, and let us know if there's one that needs replacement to request it.
Okay, and
Brent, do you have anything to add there?
Typically in the past, right before the beach season, we reach out to municipalities to determine if they need any signs to be replaced. Typically, we're not looking at a significant number of signs. We might be anywhere from 8 signs, 9 signs to be provided to municipalities. So we already do kind of have that feedback loop to replace some of those signs.
So are all the signs, so are we replacing signs that are existing signs as well, so that there's consistency?
So currently, correct me if I'm wrong, Brent, we do have signs posted to indicate the risks of swimming 48 hours after a heavy rainfall. So right. These signs would contain more information than in the current signs. But
so is that a yes? We're going to replace the existing signs? Okay, yeah. So we're not talking about 8 or 9 signs this year. We're probably talking about 60 or more.
There's 60 beaches.
Okay, so at least 60 signs in likelihood for year 1 is what I would read into that.
Right, but fewer costs in terms of.
Understand. I'm just trying to get a sense of what we're doing, and because it was.
It's got an answer.
So that there was it's going to be new signage with new content on it. At least new design.
I just want to also bring the fact. Right now we have 2 signs posted at the beach. We have the rainfall warning sign that Dr. Zimbalati was speaking of, and we also have a swimmer's itch sign. And what we're trying to do is essentially combine those 2 signs and include it on one sign for the beach to cover everything. So we will be going down with the number of signs.
Yeah, no, I get what you're saying. That the and are we going to have access on those signs? Are you going to have QR codes and so forth that people can immediately access the website so that they can see additional or information, or if there is a warning for some reason that's been posted to the website, it'll direct them to that location, that page on the site?
Yeah, so what's going to be on the or what's going to be on the sign is essentially a link to our website. Our IT department has been shifting us away from QR codes because they can be spoofed, and people can take a sticker and throw on a different QR code that redirects people to an illegitimate website. So yeah, the QR code probably won't be put on there, but there will be a myhealthunit.ca web link.
Okay, nobody's gonna look that up. I'm just going to tell you right now, nobody's going to look that up. Nobody's going to type that into their phone. Nobody's going to take the time to do it. It needs to be made as simple and as easy as possible. I don't argue with you about the QR codes, and that's a possibility. That's on us and the municipalities to be checking that then, and to know whether or not the QR codes are functioning as they should be. But nobody's going to go on their phone and type it up. Thanks for your presentation. I appreciate it.
Go ahead, Louise, before I go.
Yeah, I was just going to say, thanks for your input, Dave. And we're hoping that through our sessions with the municipalities that we'll be able to make the signs work and the process work for them as well. And so that's the sort of feedback that we'll be asking our municipalities for, recognizing that they're, working directly with their constituents to support this program.
You got two.
Obviously, there are plans for the public campaign as
well. Yeah, for sure.
We got two more questions. I'll go with Tim first.
Yeah, I totally agree with the concept of it's overwhelming and not cost efficient or effective to do the water sampling the way you are. I get that. My question is very pointed, and it's in regards to blue-green algae blooms, which are extremely dangerous to humans and animals. We have certain beaches that are closed or recommended. Actually, they are closed. One in Calendar Bay, for example. There could be others. One on Lake Nodman thing. Whose responsibility of it is to identify blue-green algae bloom and to monitor it? I'm not clear on that. Is it Conservation Authority? Is it us? Is it?
It's largely MECP that does the monitoring. However, we on a complaints basis will
Okay.
As well go in.
Well, that's my concern, because we know blue-green algae mid-August to late September. If it's going to happen, that's when it's probably going to happen. And if we know from a yearly basis that there's problematic areas in our catchment area, I just worry about going from a proactive to a reactive, and we might not be fast enough strictly reactive if we know there's potential for an area for blue-green algae bloom. I'm not worried about the other potential contaminants and like the minor sicknesses or whatever, but this one's especially harsh on humans and animals. And I'm just got a little concerned about, is there any thought in monitoring the high risk time and the high risk area, so we at least look proactive instead of we had, X number of people get sick and then, the health unit's going to step in.
So the proactive monitoring is done by the MACP. That's not our role. And we're talking about, bacterial counts being a point in time measurement in terms of E. coli. I would say it's even more true of blue-green algae, where the winds can push, the blue-green algae around the lake. So we could not be monitoring frequently enough to be able to get an accurate posting and timely for the public, because by the time we get the results, likely the situation in that area would have changed.
Good. Thank you.
I have a question now. I'll just throw it out there. Our municipality, we have on Lake Osmond, we have a swimming program in the summertime. So you've got young kids will be there learning how to swim, and you're going to put up a sign, and parents, the first thing they're going to say is, who's testing the water? What do we do now? So somehow the signs have to be well documented, or not just documented, it has to be written so they can understand it. I can just see a young family going there with their kids and see a sign, we're no longer testing these waters. So municipalities are going to get the phone call. So we just have to somehow to get on top of it before it gets to that issue. Want to answer that? I'm not sure who will, but.
So, I mean, when the wording of the signage, we're aiming for non-inflammatory, very fact-based and really about information about safe beach practices. That's the main messaging that will be on the signs. And so beyond that,
I realize that. I just gotta make sure we talk to the municipalities and work with them. I'm sure they will.
Sure.
We just got to get the right word across that so the parents understand it and everybody understands it goes to the beach. Because I know we have a beach where we, on one side, we're teaching the kids how to swim, and right next to it is it's a boat launch.
Yeah, so it's important to have those conversations with municipalities, because there may be other ways we could support. If there is a swimming program that's offered through a municipality, are there additional materials that the health unit can support the municipality with to distribute to those who are enrolled for a swimming program, for instance, or, as an example.
Yeah, that might be one. Maybe the other is that it should be sampling going on during the year or taking a look at it. So I'm just saying it's great what you're doing, but I just want to make sure that we're all covered, because we're going to get the phone calls if something happens.
The changes that we're making are enough to limit or negate any liability.
The changes we are making are supported within our mandate. So, yes.
Okay.
Please
work the same for the municipalities.
You got the answer, Louise?
Oh, sorry, Jamie, I was coming back to your question. I didn't quite hear Dave's question.
I was just wondering if it negated liability, and Dr. Zimbalati answered that on behalf of the Board of Health. I'm just wondering, is that good enough for the municipalities?
I don't know. You'd have to. Myself, I don't know how comfortable I would feel with that answer. That's all. And I'm not the one you got to answer. You got 5 other councillors you got to answer to, right? Or the CEO and the Parks and Rec. So. Okay, Louise.
Yeah, so I just wanted to reiterate, we're not looking for to be excessive burden to the municipalities in terms of answering the questions from the public. And this is why we've chosen to bring this forward in February, to give us time before summer to have the dialogue with the municipalities directly, to be able to answer their questions, to be able to tailor communication, to start communicating to the public, to supplementary programs like swimming programs, so that by the time the summer season comes, everyone is feeling comfortable with the change, that the municipalities, if they get a question, feel comfortable in answering it, and that, the signage and the communication that the health unit is doing is very supportive to the municipalities. So, appreciate all the great questions. That helps us to continue to fine tune our plan moving forward. But I do want to assure you that's why we intend to connect with the municipalities following this meeting.
If I can make one more suggestion, I said you should better get the YMCA involved, because they're the ones that do the swimming program. So the ones that want to be on site doing these. So that might be a good one to have. Jimmy Restoll.
Thank you. Through you, Mr. Chair. Just a couple of questions and a comment. And if it was in the presentation, I apologize. But with all the testing over the years, do we have data on how many warnings went out for results of testing? Or I guess that's my first question.
So there were no beaches posted in 2025. based on this testing. There were, I think, was it 3 in 2024, Brent? 2024 was a season where we had a lot of heavy rainfall. And that did impact, we believe that was what might have impacted beach sampling results.
Yeah, that's correct.
Okay. And just a couple other quick ones. In the signage that's there, and I don't know because I'm not a water person, but does it say that there is testing that takes place currently? Or is it just warnings in terms of, the swimmer's itch and things like that?
I am just looking at the signage right now. No, right now it doesn't indicate that there is testing going on at the beaches. It's just there is that rainfall warning notice. It just says, notice this water may contain high levels of bacteria for up to 48 hours following heavy rainfall.
Okay, thanks for that. And I just ask because, if we're sharing, if we've never said that beaches are tested, then I'm not sure what the impact is going to be. I know there's going to be an impact if we have on the sign that it's not tested, but we've never stated through these signs that it was tested in the first place anyways, right? So I guess everything's in messaging and how that goes out. But it's not like we're changing in terms of messaging at the beaches, it's not like we had something posted that we were testing, or the health unit was testing. So just to keep that in mind as well, in terms of how the signage looks and how the messaging is shared. And then the other thing, and this is my municipality perspective, when you're developing the signs, just to keep in mind that in our municipality here in West Nipissing, it is a bilingual community. So just the French signs as well, because I know my fellow councillors are going to be following up on that as well in terms of signage, because we do have mostly bilingual signage across the municipality. So just to keep that in mind when the signs are developed, to have, if possible, to have that translation service applied to signs here.
Mhm.
And that's it. And I appreciate the presentation as well. I always like to learn more, and Brent, your presentation certainly taught me a couple things today about water quality, that kind of stuff. So I appreciate your information shared.
Great, thanks.
All right, so take this to a head. Thank you very much for the presentation. Great discussion. And thank you again, Brent, and thank you, Louise.
Thank you for your time.
10.4.
Thank you.
Bye.
Okay. So we'll have a resolution here moved by Mr. Blair. Aaron Cook. Whereas the Ontario Public Health Organizational Standard requires boards of health to implement the governance to self-evaluation process at least every 2 years. And whereas the Board of Health last completed self-evaluation in 2020. The wrong one. I thought it was just a briefing. I didn't think there was a motion. That's what I thought. Okay, see. I did something wrong there for a second. Thank you very much for, they're gone. It's okay. It's okay.
So 10.
10.4. The formation of the ad hoc committee to support the Board of Health self-evaluation process.
Maybe I'll just briefly mention, so the last Board of Health self-evaluation occurred in 2024, April 2024. It is required to be done every 2 years. The last time around, well, I don't think in any previous time around that I'm aware of, we didn't strike an ad hoc committee. Prior to 2 years ago, there wasn't really a way to address the results. 2 years ago, I had summarized the results and provided recommendations for actions, but I think having an ad hoc Board of Health committee to look at their own evaluation makes the most sense, and develop their own recommendations following the
evaluation. So that's where the change in practice is happening.
Do you have any questions?
Do other boards do it? How do our peer boards do it? Do they have ad hoc committees? Do they bring in an independent third party? What do other boards do? I'm just curious because I vaguely remember going through it, but I don't have good recollection.
Yeah, I'm not clear on what I haven't canvassed other health units to determine.
And what do you anticipate will be the sort of the scope of work for the committee?
So the scope of work will be looking at the instrument that is being planned, and it would be recommended that we use the same instrument just in terms of best practices. But the board, the ad hoc committee may have other suggestions, and then to review the results of the survey and to develop a recommended action plan based on those results.
And if remind us, was that a blind survey that we conducted the last time?
Anonymous?
Yeah.
Yes.
Yeah. Okay.
And the board would not, the ad hoc committee would not have access to
No, they would just
individual data.
That
It would be the aggregate data.
And what staff resources will be assistive of this? And maybe it said here, I can't remember because when I read it.
It would be similar to last time. We actually even less. It'll be done through, I think, is it MS? Oh, Medallia, yeah. So there are very few staff resources unless there are significant changes to the instrument that are proposed, I suppose.
Aaron, you have a question?
My understanding is the questions can't change this time around, or it's not recommended.
It's not recommended.
Because it's the same board doing the same survey.
Yeah. So
Because there was a lot of dialogue around the questions and people weren't really satisfied with the survey to begin with.
It is best practice to use the same instrument to determine whether there's been a difference. Yeah.
I'll read the motion, and if you have any questions on the motion, we'll go again. Moved by Blair, second by Karen. Whereas the Ontario Public Health Organizational Standard requires boards of health to implement a governance of self-evaluation process at least every 2 years. And whereas the Board of Health last completed self-evaluation in April 2024, you're required to complete the self-evaluation by April 2026. And whereas the established an ad hoc committee will provide a focus on oversight and support for the timely and effective completion of the Board of Health self-evaluation process. Now therefore resolved that the Board of Health establish an ad hoc committee to oversee and support the Board of Health self-evaluation process in accordance with the Ontario Public Health Organization Standard, and furthermore that the ad hoc committee shall comprise of the Board of Health Chair, Rick Champagne, one individual Board of Health member, and the Medical Officer of Health, Executive Dr. Zimbalati, and shall serve as an ex officio and member. And be it further resolved, the ad hoc committee report back to the Board of Health in June 24, 2026, Board of Health meeting with the results of the self-evaluation and the recommended actions, and that the committee be dissolved upon completion of this mandate. And be further resolved, the remuneration for the ad hoc committee be paid in accordance with the Board of Health bylaw section 679. Discussion on the motion. See none. Rick Champagne, yes. Karen Cook,
Yes.
Blair Flower,
Yes.
Jimmy McGarvey,
Yes.
Jamie Restool,
Yes.
Tim Shepard,
Yes.
Marianne Stickland,
Yes.
Dave Wolf. Carried. Move on to in camera, 11.1. Resolve the Board of Health move into camera at 6:29. Need a mover and a seconder?
Sure.
Tim Shepard
Jamie Russell.
and Jimmy Restool. Resolved that the Board of Health move into camera 6:29 PM to discuss agenda item 11.1, the security of the property of the board. All in favor? Rick Champagne, yes. Karen Cook,
Yes.
Blair Flower,
Yes.
Jimmy McGarvey,
Yes.
Jamie Restool,
Yes.
Tim Shepard,
Yes.
Marianne Stickland,
Yes.
Dave Wolf. while you're asking, I just like to, Jamie McGarvey, I'd like to congratulate Megan Oldham. She's a gold medal winner and the silver medals in Parry Sound. So please give our congratulations, please.
Will do. We're having an event for her on Saturday. We'll start at the Stocky Center, and then we're having a street party from about 12:30 to 3:30 downtown. So yeah,
Awesome.
should be a good day.
Well, thank you and congratulations.
For sure.
Make sure that she hears that. I just got a text from her dad while we were having our meeting, and she just got home. So
Well, right on.
she's trying to
Good.
catch up.
Okay. Thank you. We have adjournment. Thank you and great discussions tonight. And thank you very much and have a safe trip home. Thank you.